So PRBCs. So PRBCs are going to be transfused for a hemoglobin less than 7. If you're a heart patient or a stroke patient, they might do 9, possibly. This one says 10, but 9 to 10, they might have a little bit higher transfusion target, especially if they're bleeding. But every unit that you give a patient will raise the hemoglobin by about 1 point, 1 gram. So we know that there's a 3-to-1 relationship, right? So that means the hematocrit will go by 3%. Okay, so PRBCs will definitely expand volume. That 350 cc's is going to expand blood volume. All right, so to be cautious in CHF CKD patients, otherwise what happens? Cafeteria is going to call and they're going to get a taco. All right, so transfusion-associated circulatory overload will occur if they get too many PRBCs. And what is too many? 2. So usually it's always 1 unit is ordered. The only time you give more than 1 unit if someone is massively bleeding. That's a massive transfusion protocol or MTP. Then we would give more than 1. But if it's just routine, hemoglobin is trending from 8.5 to 7.5 to 6.5, just 1 unit. That's it, right? So if the patient's symptomatic and BP is less than 90, heart rate's greater than 120, that is where you're automatically going to MTP. And they're going to give massive units of blood to get that patient stabilized. If they are actively bleeding, but the blood pressure is okay, all we do is give O-negative blood. All right, so we just give uncross-matched blood. All right, we're not going to wait. If they have blood on hold downstairs, that's perfectly fine. You can give that whatever blood they have on hold, and then whatever else, you give O-negative. Okay. And remember, we talked about hemodilution from the ER. ER gets a little welcome package of 3 liters of saline. It's not they're bleeding acutely, right? It could be just that they are diluted out. And you're going to definitely trend it to make sure they're not getting worse. But if they have signs of bleeding, well, shoot, that could actually be a low hemoglobin. Okay, so PRBCs are leukoreduced. As we'll come to find out, you can get infections. One of those infections is the CMV that lives inside of the white blood cells that you can't really filter out. So, or yes, you can leukoreduce it. You can take out the white blood cells. But so we get that CMV that lives inside the WCs and just take them out. So they don't have that risk factor for infection with CMV, all right, or cytomegalovirus. And then it might be able to wash or radiate the blood products, especially if they're getting either a cancer patient, organ transplant. They have allergic reactions to blood in the past. It could be a reason to give a radiated unit of blood to a patient. All right, so what else? So EDTA is a preservative. Citrate is another preservative, so citrate as well can be inside there, or EDTA can be inside the blood, because you don't want to give a clot to the patient. We want to give blood to the patient. We want to give nice, smooth, somewhat viscous blood, right? So we know that calcium is integral to many, many steps, the coag cascade. So why don't we just block calcium? And that's actually what works. So we give these guys, which eat up all the calcium. They bind the calcium, so it doesn't work. Therefore, we can give an actual unit of liquid blood to a patient. And can we take that out with a filter? No. So the EDTA or citrate will then go into the patient and neutralize their calcium. So they're high risk for hypocalcemia, especially if you give more than 4 units. Usually after 2 or 3 units, it's a good idea to check calcium so that we are not causing hypocalcemia. And why is that a problem? You're giving blood for a reason, right? It might be a reason such as bleeding. And when you're bleeding, do you need the coag cascade? You need calcium for the coag cascade. So it's like a catch-22. It's like we're giving blood, but we're going to lower the calcium to make you not bleed more. So you have to check it, right? Usually they'll even give prophylactic calcium pushes, just be after every 2 units, like in a massive situation in the room, just to make sure we can temporize them as much as possible. Okay, and then if you give old blood, expired blood, it can cause hyperkalemia. So because potassium lives inside of every cell, so if we give old blood or we give blood through a small IV, right? So small peripheral IV, that's like 22, 23 gauge, that can destroy the blood on the way in, right? Another thing that can do that is we give the wrong IV fluids. We gave hypotonic fluids or hypertonic fluids even. All right, so ABO compatibility we talked about in detail, right? For unit compatibility. So you got to make sure that you know who's getting what. I mean, you can work through this table, you can memorize this table or this table here, but again, look through, think about what I'm giving. If I'm giving PRBCs, am I giving cells or am I giving antigens or antibodies to a patient? I'm giving them the antigens, right? So the antigens are what makes it the name, right, of the unit. So the unit of blood, B blood right here, so we got B positive blood. That means they have what on their cells? They have Bs and they have RHs, right? So they have Bs and RHs on their cells, and they're going to have anti what? Anti-A. So obviously they can't get any cells that have A on their cell on it. Otherwise they're going to attack it because they have anti-A. Okay. As we mentioned, you can't give negative positive or positive negative. Which one was it? Other way, positive. You can't give positive and negative, right? You don't want to spread herpes, which is positive, right? So you want to make sure that you are not putting positive, which has Rh factor, to someone who's negative who could have anti-Rh, right? So positive can only transfer to positive. You can't give positive to negative, however you want to word that, okay? So platelet transfusion. So we talked about this. Normal platelets, about 150, 200K. If you get less than 100, you are concerned. You're probably going to stop anticoagulants. They may continue them all the way down to 50K, but you're never going to give anticoagulants or antiplatelets if you are less than 50K, right? And if you are less than 50K, you're bleeding, automatically you are transfusing the patient, right? So actively bleeding and less than 50K, transfusing. Less than 50K and plan for procedure, you are giving platelets as well to get that platelet count up. If you're not bleeding, you can go all the way down to 10K, right? So once the platelet count hits 8K, 9K, then yes, then we would give a platelet transfusion. And like I mentioned, some places are even all the way down to 5K before they start giving platelets. If you give a unit of platelets, it should raise your platelet count by about 30K. So if it's platelet count is 35K this morning and you give platelets, it should go up to 65K, right? Just like with packed RBCs, you give 1 unit of packed RBCs to someone with a hemoglobin of 6, it should go to what? 7, right? That's how 1 unit of packed RBCs should raise your hemoglobin by 1 point. 1 unit of platelets should raise, or 1 dose of platelets should be given to should raise your platelet count by about 30K. Now I say 1 dose because platelet counts are a fun grouping of all your best friends, right? All your best friends' platelets are all going to be poured or pushed into 1 bag, and that's going to be it's from 4 to 6 recipients of your closest friends are going to give you their platelets, right? And that's going to then be infused. And why is that not a problem? Because there's no antigens. It doesn't matter, right? You're just sharing is caring. So you're giving this whole group of platelets to a patient, and hopefully all those little different fragments will hopefully restore our platelet count as much as possible, right? So does it expand volume? No. It's 300 cc's, maybe like temporary in the first 15-20 minutes, but it's not oncotically active. It's not going to do anything. Okay? It can be given very rapidly. If you're giving it a massive transfusion, you want to ideally give 1 unit for every 1 PRBC, but we know that's not, platelets are hard to come by, hard to find 4 to 6 close friends, so like that many times. So you have to, it's usually like a 4 to 2 to 1 pattern, where you give platelets once, right, for every 4 units of PRBCs. And what's the 2? That's your FFP, right? That's usually what you do with a massive transfusion protocol. So there's no incompatibility because there is no cells or no antigens on those platelet cells. So FFP. So FFP is frozen, so it takes time to warm up, about 20-30 minutes. So you got to make sure that if someone orders stat FFP, you got to say, well, pump your brakes. It's going to take 30 minutes at least for the lab to even warm it up. Okay, and the goal of FFP is to provide coag factors, right? Provide albumin even, and that's going to, hopefully fix an INR. That's usually when we give FFPs. Should we give this to patients who have, who are cirrhotic? As we know, they are low in fibrinogen only. So we should give something more nuanced to those patients, right? And that nuance is something as like Cryo. Cryo has fibrinogen in it, right? That's not an F at all. So fibrinogen, okay? So that's something that's going to be great for someone that has a low fibrinogen, because we know patients with cirrhosis are high risk of volume overload, and it's not great to give them FFP because it's just going to cause more problems than good. Ideally, before we give FFP, we should give PCC if they have anticoagulant bleed, because FFP is going to work in how long? About 3 to 4 hours. So we want to give a anticoagulant reversal if need be, right? That's with their PCC, Okay, so what's a critical bleed? That's a brain bleed, a GI bleed, right, retroperitoneal bleed. These are all critical bleeds from anticoagulants where we have to give PCC immediately, right? So PCC is yes, more expensive, but it's a better substitute than FFP if someone has an anticoagulant bleed. If someone just has a regular bleed, like a trauma, then yes, that's when we would then give a FFP to try to get it, of course, thawed and make sure we are, using it to restore someone's INR, which can be elevated because they are bleeding and consuming all the coag factors and consuming all their platelets. Okay, and again, you give it like a 4-2-1. Right, so 4-2-1 is realistic. 1-1-1 is like a level 1 trauma center. They can accommodate that. So elevated INR, we can give vitamin K, but that's if there's non-life-threatening bleed. If it's a life-threatening bleed with a warfarin, then we're going to give a PCC, right? All right, so there are derivatives we talked about for FFP. PCC is our go-to agent for anticoagulants. There also other specific things for like hemophilias we can give coag factor concentrates for, and then albumin. Albumin is the protein component of the FFP, is filtered out, and we're just giving the albumin to hopefully cure what albumin's for. And what is albumin for? It's for, restoring oncotic pressure. And we talked about that a lot in liver disease, so we'll talk about that a little bit just coming up. Just another note that they do give it for, INRs that are elevated, but sometimes the INR of it is about 1.5 to 1.8 on average, right? So 1.5, 1.8. So sometimes they say keep giving FFP so the INR is less than 1.5. It's like, that's not going to happen. That's not how diffusion works. Diffusion is high to low. If this INR is 1.5, I cannot bring the INR, or 1.8 even, I cannot bring the INR any lower than it already is, right? So transfusion maintaining INR less than 1.5 is literally impossible with FFPs. Okay, so please get that order clarified. That's not a possible order to carry out, and it's wasting FFP as well. Okay, so albumin. Albumin is super, super thick. It is. You have to get it's usually glass delivery, glass syringe. You gotta make sure it's opened up. That little port right there. Sometimes put a little blunt needle in there to allow pressure to escape. So you have a way to get this albumin to flow down into our patient. It takes about 20 minutes for it to equilibrate anyways with the tubing and with the saline that might be in there. So you just got to be careful, otherwise you're going to start pulling air. And even giving gravity tubing is a more acceptable way to give it, especially in an emergency. Okay, so it pulls all the water from the periphery straight into the vasculature at a 70 times more than sodium. So it's extremely oncotically active. It pulls water wherever it goes. Okay, so it's not for volume resuscitation. It's still done by those who can afford it, right? Maybe like if you go to Beverly Hills, they say, we only do albumin here. We don't do crystalloids, right? Okay, cool. But there's no difference between mortality or anything else between those who get albumin for low blood pressure and those who get LR. There is a difference between LR and normal saline, but LR versus albumin, there's actually absolutely no difference. And oftentimes you'll see people give albumin because the albumin is low. That is 100% not a reason. That's never the right answer, right? Low albumin level is about 3.5 to 5, but giving albumin is not going to push that number in any direction whatsoever. The only way to fix someone's albumin is to fix someone's protein intake, right? So your body has to make the albumin itself for the albumin level to go up. So what is it for? So it's for our liver patients, right? They got large volume parasitesis. We got a hepatorenal syndrome. We got systolic blood pressure. We got a spontaneous bacterial peritonitis, which happens from our ascites patients, all right, due to ascites, right? Those patients need to get they get a large volume taken off their belly. They have to restore albumin, otherwise all that fluid you took off is going to fill right back up with more fluid and cause their blood pressure to be low. Okay, plasmapheresis is a reason to give it. So when they take out all the patient's antibodies from their serum that's causing problems, then they restore it with albumin. Okay, and they exchange a lot of albumin. They're asking for like 8 to 12 bottles. They're getting a huge amount. Okay, do you need to check ABO compatibility? No, the antibodies are removed. It's just the albumin that we're giving to the patient, right? It's given as a percentage, so like 25% or 5%. 5% is obviously less concentrated. It has a lot more volume compared to the 25%. It is super, super thick, as we mentioned. It's about 20 minutes to equilibrate. So we have to make sure we are infusing it, and sometimes we're going to be troubleshooting a lot with the pumps to try to get it to infuse properly, because it's going to try to pull and pull and pull. It's like drinking a smoothie that's super thick where you can put too much banana in it. Okay, so that's the idea with albumin. It's for liver complications, plasmapheresis, another reason. You may see it given as like a 1-2 punch for diuretics to pull the fluid into the bloodstream and then give a diuretic to pee it out, but there's no evidence that works. All right, so MTPs real quick. So MTPs we touched on before, but MTPs are given when you have a patient who has hypotension and they are bleeding. Right, we know that they have a diagnosis of bleeding, or we can see the bleeding. That's the time to give MTP, right? So MTP is where we're giving 1 to 1 to 1 ideally, or 4 PRBCs, 2 FFPs, and 1 platelet to try to get their blood pressure up, right? So it's a systolic blood pressure less than 90 plus plus bleeding. That is when you are going to do an MTP. Okay, and we give O-negative blood, right? The pharmacy is going to bring up a cooler with blood, and they're going to keep bringing it up until you tell them to stop, right? So this is something we call overhead, call it code MTP to whatever room, and they come and bring the cooler upstairs, and that's going to then be used to transfuse the patient. And it's going to be in a 4-2-1. Usually the first one won't have FFP because it takes 30 minutes, so the next cooler definitely will have FFP in it. So we transfuse all this blood. And we know there's a death triad with coagulopathies that we want to avoid. We want to avoid coagulopathies, and we also want to avoid coldness, right? So we give it via a warmer or a MTP machine, or level 1 rapid transfusion is a brand name that can warm the blood and give it extremely fast, right? Like the 1200 mLs per minute. And how do you give it up to 1200 mLs a minute? You have to have an IV access that is big enough and short enough to get that blood into the patient, right? So short and thick does the trick. And then we have MTP complications. We mentioned hypocalcemia with all the citrate and EDTA that could be inside the blood. And we also have hyperkalemia. If we give it via really, really small IV access, that can damage the blood. We don't give it via normal saline. LR is in the works. Just wait for it. It'll in the next 2 to 4 years, you'll see LR as a better alternative as a carrier fluid. But right now, NS is the recommendation from like national organizations. And then hyperkalemia will result if we use the wrong fluid. If we use hypotonic fluids, all that hypotonic fluid is going to rush into the RBC and pop it open and cause breakdown. Okay, so the key thing with MTPs is the blood's going to keep coming and keep coming. You have to check to make sure they're not getting hypocalcemic. Make sure that we're restoring their counts, right? Make sure the fibrinogen is going the right direction, because maybe we need cryoprecipitate, right? Make sure the INR is getting corrected. Make sure the hemoglobin is stabilizing, the blood pressure is stabilizing. So these are all the things we balance with someone that is massively bleeding with us, right? The INR is less than 1.8. You can say, oh shoot, and the family comes, do they take anticoagulants? Do they take warfarin? Do they take a 10A inhibitor? Do they take, are they on, it would be on heparin at home because that's IV, but are they on something that's going to make them, be a higher risk for bleed? Then we could give reversal agents. So that's the idea with these guys. Get the platelet count corrected, INR corrected, so we prevent further bleeding and also prevent the low calcium that will happen with these the things that are going to precipitate out calcium. All right, so blood transfusion complications. So really talking about PRBCs. Yes, it could happen with FFP transfusions, but this is really where you're giving the wrong cells to someone who has plasma that's attacking it, right? The plasma has anti-A, for instance, right? And who is not compatible with anti-A? Someone that has A on their cells, right? Who has A on their cells? A and AB, right? So you cannot give those cells to someone who has anti-A in their serum. You have to think of the blood product you're giving to your patient, right? You give them packed RBCs, so you can't give them AB or A if they have anti-A in their serum. Who has anti-A in their serum?
B.
So it's type B blood or O, right? We didn't get into RH factor, but that's also a factor, right? The most common transfusion reactions by far is a febrile reaction. That is like 100% very, very common, and the first thing you do with any kind of transfusion reaction is to stop the blood immediately. And as I mentioned, off this this blood product, you have these little sticks, little honey sticks. Like if you get by like the side of the road, little honey sticks, and they're like, oh, that looks nice. And they're like little danger sticks. They're usually for like vampires and for checking a transfusion reaction to see we stopped it, and we're going to send it down to the lab, and they're going to test it to see what might have happened. Was it a clerical error that caused a transfusion reaction, or is there something that they missed that they need to do further testing on? Okay, so the ultimate goal is to make sure that we are stopping the transfusion. And there's a lot of transfusion reactions that can happen, and we can separate them out into two categories. Okay, those categories are immune or non-immune. So we're attacking the cells, or we're just like, whoa, what's that? I'm going to create a immune reaction to it. And that first hit is like, oh my gosh, what the heck was that? That's a febrile reaction. That's extremely common. 1 per 20. So if you give 20 packed RBCs, or I guess 20 packed RBCs, but 20 patients that get 1 packed RBC each, you're going to have one of those is going to have a febrile reaction. It's extremely common. Okay, so that's a common thing you see, and that's just where you have a 1 degree elevation in someone's temp. And yes, you're going to stop transfusions for any kind of transfusion reaction, and you're going to call somebody and say, what do I do? Right? And if they have a fever, you're going to give a Tylenol or give acetaminophen, and they're probably going to let you give the unit still. They're not going to like, oh, send that down to the lab, get it tested. It's probably just a febrile reaction. They're going to ask you if there's any other symptoms that might be there. If there's other symptoms, then it could be like an allergic reaction, for instance, which is also immune mediated. That means there's antibodies inside the serum that we did not test for. There's not only anti-B and anti-A and anti-Rh. There's actually like 12 other ones, right, that we don't even need to learn about. But they're uncommon, but they are there. You may always hear like, oh, we can't give blood. The patient has antibodies. What does that mean, right? So they had to find the exact blood type that meets all 15 options, right? That is not going to cause any kind of transfusion reaction. And they found that out because the patient got a transfusion in the past, right? And how do you know someone has an allergic reaction? Well, they have allergies. They got pruritus. They got itchy skin, right? They got hives that are forming, right? They have anaphylaxis. Is extremely rare where they have like the airways swelling off and they have anaphylactic shock. That could happen, but you're definitely going to stop the transfusion, and you can give steroids, antihistamines, and epinephrine if you need to. And hemolytic reactions we talked about in detail, right? That's only a clerical error. There's no other reason for it. Okay, and then we have TRALI, transfusion-related acute lung injury. This is literally ARDS in a bag, right? So how often does it happen? 1 per 10,000. So it's pretty common that, do 10,000 people get PRBCs in America? Yes, right? And in America at any one time, there's a lot of people in ICUs, right? So you have a risk factor of getting TRALI, or even hospitalization because they get a unit on the floor, right? They have a risk factor of developing ARDS, and there is no treatment for this. It's just they develop ARDS from getting a transfusion, right? It's not associated with like 6 units or 12 units. It's just that 1 unit happened to cause this patient to go into a full-blown SIRS and ARDS crisis. So we have those immune-mediated reactions to the blood, and we have non-immune-mediated. That means there was TACO, one of my favorite transfusion reactions, right? They got transfusion-associated circulatory overload. They got 2 packed RBCs for hemoglobin of 6.5. What are you doing, right? We know that PRBC is going to raise by 1 point, and if they're not bleeding, you don't need to give 2 units, right? It's just 1 unit and then check again. And ironically, if you check again, you cause iatrogenic anemia, where you lower their hemoglobin and their RBC count just by doing the blood check itself. Okay. So we talked about electrolyte problems that might jump up, right? Low calcium, high potassium with the wrong unit, not wrong unit, but wrong size peripheral IV, or we have too much preservative that's binding all the calcium in the patient. And then iron overload happens when you have too much iron. So that's when you have too many PRBCs, like 25, 30, 40 units of PRBCs over a short period of time, where the body can't get rid of that iron, can damage every single organ system. And then infection. Infection is a risk. Everybody was super scared about HIV, but the last documented case is like 2001, where someone got an HIV-related transfusion reaction, or transfusion infection. But Hep B, Hep C live in blood, so it's possible for that to happen. CMV is in blood for sure, and what do we do to reduce that? We give PRBCs that are Leukoreduced. Not with LR, lactated ringers, but leukoreduced. Because CMV lives inside of white blood cells. We take the white blood cells out, you don't get CMV. All right, so allergic versus febrile reactions. Those both have fever. So positive fever, sort of. Positive fever is present on both of these guys, right? So how do you know someone has anaphylaxis versus a febrile reaction? Anaphylaxis obviously has allergic reaction, allergic versus febrile is someone who's allergic is going to might have anaphylaxis, right? They could have that wheezing and shock state. That's extremely rare, but what's more common is they'll have like the pruritus and urticaria. They'll have hives and itching all over their body. That's how you know someone's having a allergic reaction. A febrile reaction is just the temperature elevation. That's it. And both of these guys, you're going to stop the transfusion. That's a given, right? We're stopping the transfusion. We're going to reassess, see what's going on. So, you'll look at their skin. If you got any rashes going on, you feel any tightness in your throat, of course you can let me know. But what is the what's going to happen next? Well, they might give some steroids and such. They'll check it to make sure there's not any other antibodies that are circulating in this patient's bloodstream, because they could have what are called antibodies. So it takes them a long time to find the right unit at the blood bank for this patient for the next time they get a transfusion. Okay. Whereas febrile, you're going to stop it. A 1 degree elevation technically is a febrile reaction. That's why we check vital signs 15 minutes in. And that's going to get, what are they going to do about that? They're going to say, okay, just give Tylenol and then continue to monitor. If they start developing hives and rash and such and itchiness, then yes, then that's now an allergic reaction. All right, so ABO compatibility we talked about was extremely rare, right? It does still happen, and it's only because of a clerical error. There's no other reason for someone to get an ABO transfusion reaction unless someone didn't pay attention to this lecture or didn't pay attention in nursing school, because that was why you have an RN license, to make sure it's the right unit, right? So the person downstairs, is that they're not the one that's giving the blood to the patient. When they go to court, it's not going to be their fault. It's going to be your fault, right? Because you're the one, it's also the person you witnessed with. So both of you are there to witness it's the right unit for the right patient, right? And also they consented to it too, because they know what they're consenting to is there's a risk factor for complications, okay? So ABO compatibility, how do you know someone's getting it? Well, they're agglutinating. So how do you know someone's, are you agglutinating, sir? No, you're going to say, they're just going to start clotting and clotting and clotting and causing blockage of the kidneys. They'll get back pain. They'll start getting dark urine as that agglutinated substances are getting discarded in the urine. So, you're not going to wait for them to have urine output for 60 minutes. Like, if they have the back pain, all of a sudden they start getting the fever and this immune response that's happening because of this ABO incompatibility. That's going to cause a widespread agglutination throughout the whole body. Obviously, you want to stop the transfusion so there's less damage to the kidneys, there's less damage to the other organs, because it's going to block a lot of organs and cause a lot of organ failure. All right, so you can give IV fluids, but there's really not much else we can do. Just got to hopefully your body will get rid of those agglutinated things and not a lot of blood got into the patient. Okay, and then there's transmission of stuff. So there's CMV we talked about. We can leukoreduce that to make sure we don't get the CMV virus or the cytomegalovirus, which lives inside of white blood cells. And then Hep B, Hep C is extremely rare, but it can happen. Hep B is more common for getting to develop that. But of course, we have antibodies, or we get vaccinated at birth to prevent Hep B from forming. Okay, it didn't really make sense anywhere else, but we put it as non-immune mediated, where you have excess of iron. These guys, all the kidneys the organs shut down, including the kidneys, right? Everything starts shutting down. Their skin gets full of iron. Their liver gets full of iron, and they start, liver can break down, getting jaundice, but also their skin gets this eternal tan. There's only two reasons for an eternal tan. One is too much iron, and one is too little steroids. You need to add steroids to these patients, which is Addison's. Addison's disease and iron overload are the two reasons why you would have skin that looks like this, right? This gentleman does not have any iron overload or Addison's disease. So one president did, John F. Kennedy had Addison's disease. He was eternally tan. Okay, so how do you fix that? You have to de-iron someone, all right? So you have to give defuroxamine, so de-iron. So taco versus trolley. So it's Taco Tuesday when you give 2 PRBCs, right? When it should have given 1. Now, if they are actively bleeding, yeah, you could give 2, 3, 4 units. So they're massively bleeding, and you got to be alert. Say, oh, shoot, this patient has a history of CHF. Are they okay, right? So you're going to assess those that are high risk for fluid volume overload, so your renal patients, your CHF patients, and then, of course, elderly as well. And it usually happens within 6 hours where they can't really equilibrate all this extra volume, right? Because PRBCs are a little bit osmotically active, kind of like albumin, not as strong as albumin, but they are going to pull some volume in just a little bit as well. We're going to stop the transfusion. It shouldn't be taking more than 4 hours to do a transfusion, but if they're getting 2 units, right, over, you give one over 3 hours, the other one over 3 hours because they're risk for fluid overload, and why were you giving 2 in the first place? Usually, you're going to obviously stop the transfusion, and probably we're going to be giving furosemide. You're giving diuretics. And sometimes they'll say, give 2 units and give, furosemide in between. It's like, well, can we just give 1 then and give furosemide after? And then let's check the blood counts afterwards. That's the better strategy. Right? There's no evidence to give 2. Right? The evidence is saying to give in 1 and checking later. All right. These patients may need to be intubated, so they may get to the point where they're fluid overload to the point where they need to be tubed. So it's not just to wash, to laugh off like a febrile reaction. It is something that can lead to being mechanically ventilated. Okay. Another reason why you need mechanically ventilated is TRALI. Okay. So TRALI is a transfusion-related acute lung injury, and it's really just ARDS, right? So you have this huge immune response throughout the whole body, including the lungs, that surge response that causes ARDS. It's not the heart that's at fault, which was what happened with TACO, right? TACO was the heart couldn't accommodate this fluid. It was a cardiogenic pulmonary edema. This TRALI is ARDS, and ARDS by definition is a non-cardiogenic pulmonary edema, right? So it's a pulmonary edema, all this fluid is developing because of this immune response. It's not just fluid, it's proteins and inflammatory markers and other things that are filling up all the lungs, right? It's not just at the hydrostatic pressure areas of the hilum and by the pulmonary arteries, right? It's all the lungs are filled up with fluid. These guys are extremely sick, right? They have extremely out of control systemic inflammatory response. It can cause hypotension. It can cause them to require mechanical ventilation, as ARDS often does, and and it's just supportive. There's nothing we can do. It happens within about 6 hours or so. So usually the unit is long gone, but if it's happening during a unit, we would of course stop the transfusion. But it is again non-cardiogenic pulmonary edema, right? It's ARDS, or the PF ratio is very low. When we're looking at their ABG, it's like their FiO2 is 100%, PEEP of 14, and the PO2 is 78. It's like, well, shoot, that's extreme. That's a lot of effort, a lot of oxygen just to get a ratio of 78. That's a huge problem. Okay, so it's this huge surge response. You might get a low blood pressure as well. They have severe hypoxia, and it's the most deadly complication there is. That's why we have a transfusion target of 7, right? Also, when you give units, right, they're going to raise it by 1 gram. But when you look at the hemoglobin, it's actually plus or minus 0.5. So hemoglobin of 7 could be 7.5 or it could be 6.5. So that's why trending is one of the most important things when you're giving units. We want to avoid any kind of complication that might occur from a transfusion reaction.